It's a tremendous pleasure to welcome Professor Eric Taylor from the Institute of Psychiatry, Psychology and Neuroscience in Maudsley Hospital, King's College London, who's really done landmark work in the treatment of ADHD and who's going to update us about the management of ADHD. So without further ado, let's go over to Professor Taylor's talk. We'll then have a few minutes for questions afterwards and then my closing remarks. Thank you very much. Bye.
This is talking about the current understanding of ADHD, which is not just as a childhood problem, but is a complex problem with many influences, complex influences on mental health problems later. So intervening in childhood, in adolescence, and in adult life need to address a number of different coexistent problems and multiple outcomes changing over time. Using stimulants, but not confined to stimulant use. The previous understanding of ADHD has been a childhood problem with a persisting pattern of attention problems and impulse control problems that interferes with mental functioning. It's not just a problem of bad behavior that can go with it, but they're different things. And defiant aggression is in itself a problem in young people's development. So ADHD is a description, not an explanation. It's one of combination of impulsiveness and attention overactivity, but very often existing with other difficult problems, especially defiant aggression, oppositional and conduct disorder, autism spectrum, and emotional lability. Highly heritable, about 75%. Complex because there are many gene-environment interactions. There are many patterns of neurocognitive impairment, not just an attention problem. It affects about 4% of children across countries when you take research measures and count heads. The actual diagnosis of it varies greatly. It's about 1% in Europe. It's more like 9% in the United States, or in some states of the United States. And medication is effective in childhood, at least in the short term. How far does it remit? Well, it depends what you mean. Loss of all the problems, symptomatic and functional remission, that doesn't happen very often. It usually persists. But you do very often lose the full diagnostic status because the full diagnostic status in the DSM definitions are essentially childhood definitions. If you follow down the rates as children age, with the time of follow-up, children who've all had ADHD to begin with, then as you get into the 25 to 30-year follow-ups, then the majority are still having problems of some kind. Several countries have followed up diagnosed children. So it's striking because they've mostly been treated, and often treated in great centres, which are very experienced, and very often treated with stimulants, which are a powerful treatment. The figures are showing whether ADHD actually persists into adult life. The persistence does matter. This is one particular follow-up in New York, which is impressive because it was followed up by the same researcher, Rachel Klein, who was identifying the children when they were back in their childhood. And then when you're comparing them with controls for age and sex and socioeconomic status, then the children who were ADHD are 30 years later, typically when these children are more or less 40 in their 40s, they're much more likely to be poor by New York standards. They're more likely to be unemployed. They're less well educated. They're prone to divorce, and they're much more likely to be dead. The actual diagnosis in that New York study is that having ADHD is still much more common than in children who do not have ADHD, but it's not the biggest problem. They're often antisocial. They're much more likely to ever to have shown a conduct disorder during their development. Substance use is more common. They're more likely to have been imprisoned. And if we think how this applies in a UK setting, there have been many UK studies showing how strongly adult behavior is predicted by childhood behavior, and in particular, conduct and oppositional disorders, antisocial mental health problems in adult life are strongly predicted not by whether you ever had it, but by when it started. So a childhood onset is much more likely to be persistent. And it's those very early onset conduct problems whose sufferers are very often the prison population now. Some of that is because the defiant aggressive children did have ADHD as well. Sometimes it's because they're more likely to have shown neuropsychological changes, problems in learning. Sometimes it's because they may just have been defiant without the other problems, being inattentive or ADHD. But of course, some of them would have both problems of both ADHD and defiance, aggression. Now, to follow that up, we made a population study in which we divided in childhood onset, divided into those different hyperactive, defiant, and inattentive groups. We did a population study in the London Borough of Newham, where we identified all the 7-year-old boys in school and identified from health records as well. And then when they were 7, we got them rated by their teachers and their parents on the Rutter scales with quite a good compliance. From teachers, a remarkably good compliance, and from parents, a surprisingly good compliance. We stratified them behavior into those separate groups. Those who in childhood were hyperactive, those who were defiant aggressive, those who showed both problems, and those who showed neither problems. We also had a group who didn't show either of those problems, but were inattentive. We made a random selection in each group. We winnowed the numbers down so that we could look at them in detail. We took detailed psychiatric interviews, tests, and observations. Now that stage with good compliance. We followed them up 10 and 20 years later with a variety of outcome measures corresponding to the great variety of problems that we have to think about in helping development of these young people. Interviewed the parents. We give a psychiatric interview to them. Cognitive testing. The Home Office records of offending were important to us. We looked at the school records, and putting all the information together, we had a diagnostic case conference that was blind to what they'd been like when they were 7. The key thing we found was that mental health problems data, any psychiatric diagnosis, is in this long, dark column. Perhaps not surprisingly, we found that that group, in view of previous knowledge, we did find that that group of the mixed problems were both defiant and hyperactive, were very prone to a mental health problem. Nearly half of the children, 40%, were still showing a difficulty. Perhaps not surprising, it was more surprising to find that those who were only inattentive and impulsive, only hyperactive, they had very much the same level of risk as those who were in the worrying version, and much more common than those who were only defiant. And that difference was marked, and they were both much more at risk than the children who'd had neither problem. "20 years later, we came back to see them again, and again we took a variety of measures. We now just compared the hyperactive group when they were children with the control group who weren't hyperactive, and see what that contrast looks like now that they're 27. And we found that the persistence of ADHD does matter. If you persist, you're much more likely to be associated with more psychiatric diagnoses, especially antisocial problems. More likely to have persisting frontostriatal changes, and more likely to be poor in negotiations, more likely to be misusing substances, and more likely to have problematic relationships with partners. So even though stimulant medication is very effective in reducing core ADHD in childhood, the epidemiological group who weren't treated with stimulants, so even though you can treat them in childhood, the key problem outcomes are with difficulty of conduct, including antisocial personality, emotional lability, wildly fluctuating mood, and going with that, a high rate of suicide, which was the main cause of death in this group. Death and together with accidental deaths, because they run into the road at foolish times. High rates of substance misuse, occupational and educational adversity, and problems in using treatment and understanding their own difficulties. So we have many outcomes to think about, and I'll try and take them separately, because it matters what we do. And I'll try to say something about what one can do in practice to mitigate those adverse risks that ADHD entails. To think about the development of antisocial problems, of conduct problems, first of all. When children are 7, there's the hyperactive group, as you've seen, who are particularly at risk, not only for being hyperactive, but also for antisocial problems. These blue boxes represent the rates of defiant aggressive problems. That high risk at 17 for behavioral problems and conduct difficulties from the hyperactive group, even if they weren't antisocial when they were little, we could look at the predictions of that. And the big predictions are a hostile, critical, emotional atmosphere at home and poor peer relationships. Because when they were 7, they weren't part of a peer group, or not part of a pro-social peer group, certainly. they were sometimes part of a delinquent peer group. And to get around that, then treatment in childhood and adolescence does need to concentrate on improving parent-child relationships, especially with behavior management, and group social skills training in helping children to learn the basics of how to relate to other children in peaceful and constructive ways. 10 years later, the children are 27. The group who had hyperactivity and defiance when they were little, and the group who developed to grow out of their hyperactivity, but to maintain antisocial problems, they were both very much at risk for antisocial problems in their 20s. The black boxes indicate that there are other kinds of dysfunction that come as well, like all the personal problems. But for the children who'd maintained only in hyperactivity and had not developed antisocial problems, they were very unlikely to develop antisocial problems when they were in their 20s if they hadn't already shown it by 17. So it is important to assist the pro-social development of young people who are at risk because of their hyperactivity. There's also a group of young people I put in this separate box because in their 20s they are hyperactive, but they weren't when they were little. And that is probably a different group. And the Dunedin study identified a group of adult onset ADHD who had not been hyperactive in their childhood. And that group is probably rather different. And if you are seeing people who are referred because of their ADHD, and these males who are referred because of their ADHD but didn't show it when they were little, there are probably new causes. It may simply be that they were female, because the presentation of ADHD in females in childhood tends to be much more inattentive and much less hyperactive impulsive. But there are new causes. Internationally, rheumatic fever and cerebral malaria are well-known causes of developing inattentive impulsive problems. Early onset dementias are starting to appear, and the changes in dementia are equally profound to those shown by ADHD children developmentally. Cannabis use is probably responsible for quite a lot. But acquired brain injury is also caused of secondary ADHD, often but not always as part of a confusion and personality change. For substance misuse, as another kind of outcome, it's mediated by whether conduct problems have developed. So if conduct problems do develop, then that's a real risk factor for substance misuse later on. And social adversity is a risk for both. For ADHD, it's not so much due to social adversity when they're little, but genes and brain insults come in very much. Now, if you haven't developed conduct disorder, you're still increasing your risk for substance misuse, especially tobacco smoking. And to get around that, then Cochrane reviews show that you have to teach the skills of refusing. It's not just that you're teaching knowledge of danger. So you have to learn how to say no pleasantly. And very often the people who teach them are people who've had that problems themselves in relating to other children because of their ADHD. Suicide attempts, similarly. This is now from a population study, not in Europe, but in Taiwan. And your likelihood of being free of suicide attempts falls very rapidly as you age. And over the 8, 10, 12-year follow-up period, suicide attempts become very much more common, and your likelihood of being free of them falls if you've had ADHD. Some of this, I think, is due to the problem of emotional stability. You can be very impulsive in your emotions as well as in your behavior control and your concentration. And recognizing that, recognizing the emotional lability in ADHD and treating that, often with stimulants and with psychoeducation, are the key ways in which you can reduce the high suicide rates in people with suicidal thinking in ADHD. Educational outcomes are importantly compromised in young people with ADHD. This is from the UK ALSPAC study, a cohort followed up very effectively. When in that study, were hyperactive and inattentive, then when they were followed up at school leaving, there was a 42-point decrement on their psychological tests, and more importantly, the GCSE grades are compromised as well. So you lose about 7 GCSE grades as a consequence of being hyperactive or inattentive. And it was largely the inattentive, which is the reason for losing GCSE grades. There's still an educational risk after allowing for conduct problems and after allowing for IQ. So, in helping to promote the development of young people with ADHD, you do need to put in some classroom adjustments. You need to have a suitable education for teachers. You need to think about examination accommodations. But so far, the direct medication and direct training of attention and neurofeedback are not very effective in moderating the educational outcomes over the school years for young people with ADHD. I've referred to emotional debility, very rapid, often big mood swings, not with the length of bipolar disorder, often a matter of hours rather than weeks. But it's very much associated with irritability and it is in itself a problem in itself that the emotional impulsiveness means that you need to add the idea of mood dysregulation to thinking about the emotional life of young people, and to mania and depression in the DSM-5, mood dysregulation is added, and the important things to do here are not the standard treatments for depression, which don't work, but using stimulants to control ADHD does work. Social interventions to recognize and plan episodes of mood change, that needs to happen. Antipsychotic drugs are effective, and anti-epileptic drugs, especially lamotrigine, do have a role if the stimulants have not worked in controlling the mood dysregulation that affects many people with ADHD. In American cohort studies, then you have to think about dimensions rather than a diagnosis. So one of the components of ADHD is attention problems, and another is impulsiveness. And ADHD, and in particular attention problems, that's an antecedent of education failure, as we've seen. Impulsive behaviors, by contrast, are not a risk for education failure, but they are a risk for antisocial development, for substance misuse. Headstrong personality dimensions is a risk for antisocial. And the emotional lability of irritability is a risk factor for depression in later life. Also in later life, as you enter it, there's a whole new set of demands that you have to consider and cope with. It can be harder to study, it becomes more important, but you have to be able to regulate yourself and not just be regulated by teachers. You have to submit to unreasonable people, because most teachers are reasonable, by contrast with the people, with your employers in adult life. Your friends will be more demanding. Your partners would expect more sharing from you. And drugs and alcohol remain major risks and temptations. And you have a budget to negotiate, which needs quite a lot of good executive function. There are some helpful things as well. But in general, there are new challenges to face. Helping young people to face those challenges, first of all, the non-drug interventions. I'm trying to divide them here into those that are valuable and ought to be used, probably more than they are. Psychoeducation, understanding your difficulties, understanding what you can do about it, and helping family and school and sometimes practitioners to recognize ADHD, take it seriously. School involvement by professionals is probably helpful. Coaching is probably helpful. And elimination diets, eliminating E numbers, is probably a minor help. Very commonly used things, omega-3, polyunsaturated fatty acids, cognitive training, neurofeedback, probably don't work, at least not on the core problems of inattentiveness and impulsiveness. Stimulants do work. There have been many systematic reviews. Stimulants and atomoxetine, with methylphenidate and amphetamines heading the list, dexamphetamine and the newer lisdexamphetamine. Numbers needed to treat are very low. Every 2.5 patients you treat, or with amphetamines every 2 treatments you treat, will show a good result. The effect sizes are very big by psychiatric standards, almost a full standard deviation. And methylphenidate and amphetamines in adult life are not very problematic. There are difficulties. You can get a headache. Growth reduction can be a problem. You have to monitor growth. But the advertised problems of substance misuse and suicide are probably not risks of stimulant and atomoxetine drug use. The long term may not be so great. This is an American study, a big study where nearly 600 subjects were given a trial of multimodal interventions, which is the most intensive interventions that I think anybody has tried anywhere. They were randomized at the beginning to careful medication management with careful follow-up and increases of dose whenever it was necessary. Intensive behavior therapy, much more intensive than anything we can do in practice here. The combination of both and a control group which were just sent to their personal physicians with a recommendation for treatment. And very often that did lead to being treated in the community with medication as well, but not the carefully controlled medication. The core ADHD problems of inattentiveness and impulsiveness were still there 14 months later. But by the time they'd been treated over a 3-year period, there's no more benefit detectable. So decreasing use over time is probably for 2 reasons. Partly it's because children stop taking them. And in particular, when you get to 16 and school leaving, and even more 17 and 18, then anti-ADHD medications are used less and less and less. It's also because tolerance develops, which you might have predicted. These are PET studies of dopamine receptor availability. And these are raclopride images, where first of all, treatment-naive people with ADHD who have, by contrast with controls, they show even more free. They don't have as much effective binding of dopamine ligands. They don't have as much dopamine in the synaptic, in the midbrains. When they've been given their first dose of intravenous methylphenidate in their 20s, they've never been treated before, but there's a very big difference between placebo. Now, when that's done later, it's more subtle, it's harder to see in the picture. But what the stats show is that the difference between being given placebo and given IV methylphenidate is less marked in the young people who've had long-term treatment with stimulants over time. So the waning of effect and the lack of effect because it's not being taken can come out for several reasons. And the action you take over time as a clinician trying to supervise their development is not because treatment effects are being underestimated. It's not because there's no long-term benefit. It's not because they're ineffective in adults. It's not because the problems have disappeared. Rather, it's probably a combination of reasons. And to prevent the development of tolerance, it can be very sensible to have intermittent periods in which the medication is being discontinued, both to assess the continued need for it, but also, hopefully, but not proven, to delay the development of tolerance to it. But it's also reason for maintaining contact, continuing advice, and thus improving the long-term mental health outcome So I've tried to argue, we'll go on shortly on to questions and answers, that the risk from ADHD in childhood does indeed persist at least until you're in your 40s. It's not only a childhood problem, it's an adult one too. It deserves the attention of adult psychiatrists, perhaps especially those involved in forensic and addiction services, but also those concerned with personality problems. If the ADHD persists, adjustment is worse, so it's worth trying to maintain adjustment over time. You can separate the pathways to antisocial, emotional lability, substance misuse, and occupational problems. There are many other problems. You could think about managing it as a mixture of persisting disability and with advice and help and support over that time, but also making the best possible use of controlling the stimulants, which remain our most powerful short-term treatment, and even in adult life, a very powerful and effective intervention, at least for short periods. Thank you.
Thank you very much. And we're now going on to the questions after that wonderful lecture. So we have Professor Taylor here live. So my first question from the audience, Eric, is about the ways in which ADHD may present differently between boys and girls, and whether this changes over time, I suppose.
Yes, powerful question. The girls are much more likely to be just inattentive and not to have the disruptive behaviours that go with it. It's not only that they're less likely to have hyperactivity, they're just as likely to have emotional impulsivity. And indeed, it's probably quite an important cause of the suicidal risk in young women. Emotional lability used to be part of the definition of ADHD. It fell out of favour because people wanted to present it purely as a neuropsychiatric problem. But in practice, it's one of the major things. And in the outcome of young females, they're particularly troubled by the problems in peer relationships, which matter a lot more to girls than they do to boys. So it's more a social and emotional problem in girls. Stimulants still help.
Okay, thank you very much. And the same questioner asks about an acronym called HIDE. Hyperactivity, impulsivity, HIDE. Hyperactivity, impulsivity, distractibility, and emotional dysregulation. Is that a discrete syndrome, or is it just part of the overall ADHD?
It's another description. It's more attractive to people who don't like a medical model. And in schools, it's much more helpful to talk with teachers about hyperactivity, impulsivity, which they understand, than to talk with them about ADHD, which they find a suspicious concept, over-medicalizing, and especially too likely to lead to medication. So the stigma about ADHD is partly overcome by talking about hyperactivity, impulsivity. It's a very reasonable way to talk to people.
Thank you. So next question, are emotional lability, mood dysregulation, and emotional instability all the same thing, or are they just overlapping?
I think they are pretty much the same thing. In ADHD, I mean, there are other causes, of course, and some people are emotionally unstable because of bipolar disorder developing. The big difference is between the episodes lasting days on end of bipolar disorder and the episodes lasting minutes and hours in emotional lability. There's a good distinction to make because stimulants help the emotional lability. They do not help. In fact, they're usually contradicted in frank bipolar disorders. So they are different, but emotional lability is very common in teenagers anyway. But it has an important consequence, and it's worth taking seriously. And it is helped by stimulant medication. It's not a contraindication at all. It's an important influence on young people's development, and part of their learning how to control themselves is part of their understanding, and it's one of the things that talking about ADHD helps, because it helps to externalize it, and they regard it as an unstable attribute of themselves rather than an inherent quality.
Yeah, I think you probably answered this, but is there any other way of distinguishing emotional lability due to ADHD from bipolar spectrum disorder?
Well, I think it's partly the other things of ADHD are present, but they're often there too in people with affective disorders. I would say that it is an affective disorder in itself, but just a different kind. I think extreme euphoria is not very common in emotional lability. It's much more likely to be angry irritability. It's much more like agitated depression. And I find it quite difficult to distinguish between agitated depression mood and emotional lability, except by the passage of time and the regularity and the episodicity.
Yeah. Great. So should teachers be trained more about ADHD? And the questioner points out that their partner is a teacher and was trained on dyslexia and autism, but nothing about ADHD.
Yes, it is. It is. There are things that happen. I work with a counselling charity, place to be. The language that people talk within the schools is very much more the language of attachment and psychological trauma, rather than of enduring neurodevelopmental problems. And I find it unhelpful to try and break that. I think the language of hyperactivity, impulsivity is much easier to use than the language of ADHD. When you do use that kind of language, teachers understand it completely. They say, "Of course, I've got more kids like that." So they
does long-term. Oh, sorry, Eric, go ahead.
Providing you stick in counselling with young people and teachers, you stick to the presentations that they recognise themselves, the emotional ability, the activity levels, the poor impulse control, and then they know what you're talking about.
Okay. I think you covered this in your talk, but one of the questions is about whether people get addicted to the stimulant medication.
Not if they're given properly. That's to say, if you inject amphetamines, people are just as likely to develop dependence and harmful outcomes as anybody else. But the time course of action is crucial. So you're taking it orally, and very often you're taking it in a modified release format. So you don't have the seconds of onset and then wear off that you get with an injection or with snorting it. If you're taking it orally and in extended release, then you don't get that high and you don't get the low. You can get the helpful effects without the addictive risk. I can only think of one child who I've treated sensibly, who developed an excessive emotional reaction to it, and that was a child with phenylketonuria, interestingly. But otherwise, it's virtually unknown as a problem.
Last question. What is the commonest substance misused in teens and adults with ADHD? So what's the commonest? Is it alcohol, or is it stimulants, or is it
cannabis? Easily, it's an easy first. Alcohol is quite a good second. They're not usually taking enough to get the consequences that come in with chronic. Mrs. Cocaine, so far, is a relatively uncommon problem, but I think it's increasing.
Great. Well, we're out of time, Professor Taylor. It just remains for me to thank you very much for such a clear and expert overview of a field from which we've all really learned a lot. Thank you very, very much indeed. Very nice to see you, actually. I haven't seen you for over a year, so, so it's very nice to clap eyes on you, even if it's just via a computer screen.